start actually.
Yes, we will start. Yes, sir. So, good evening, respected neurosurgeons. Welcome to MCNS webinar. So, this is the present webinar is around, we conducted around 5 webinars, and this is the 6th one. So, Dr. Sarang, who is the secretary of MCNS, he has some emergency. So, I would start this webinar. So, we have many consensus, and many times we debate between which is the best technology. And since endovascular technology is coming up in a big way, the more the number of aneurysms are getting clipped, we are able to see that there are very less number of vascular surgeons coming into picture, and many are not preferring to get trained as a or called as a vascular surgeon. So even the exposure to these cerebrovascular surgery and even like clipping or and cerebral bypasses has significantly reduced to the younger generation of new surgeons. So we need to embrace the newer technology. At the same time, we need to be updated with the older ones also, so that the same techniques and concepts we can apply in other surgeries. That is how we evolve as a new surgeon. So today we have the main topic of the webinar is choice versus consensus in the management of cerebral aneurysms. So we are in between endovascular technology and clipping, and where we can combine both, we are just going to discuss in this webinar. So we have very eminent speakers like Professor Girish Menon, who is my teacher from Sri Chitra, and then he was served as ex-HOD of Manipal, and now serves back to Trivandrum. So they will be speaking on surgical clipping, the enduring gold standard for durability in aneurysm surgery. So the next speaker is Dr. Nitin Dange, who is a neurosurgeon, dual hybrid neurosurgeon, hybrid endovascular surgeon, who does even clipping and coiling both. He'll be talking on endovascular coiling and beyond, the choice in the era of flow diverter and webs. So the third speaker is Dr. Kishore Chaudhary, who is the chairman of our MCNS webinar committee. He is a neurosurgeon, senior neurosurgeon working in Sheffield, UK. So he'll be combining both, and he'll be concluding like beyond clip or coil, multidisciplinary decision making in cerebral aneurysm management. So we have two speakers, Dr. Paritosh Pandey sir, who is a hybrid neurosurgeon who does both clipping and coiling, and he is from Bangalore. Dr. Sir is from Manipal Hospital, and the other one is none other than Dr. B.K. Mishra sir, who is a senior most vascular surgeon of India. So I'm myself Dr. Shushankar Marzake. I'm the convener of MCNS webinar committee, and this webinar will be moderated by me and my co-moderator, Professor and head of the Department of Chemo Hospital, Dr. Dattatreya Mujumdar sir. So without wasting much of time, I would invite my teacher, Dr. Girish Menon sir, to start with his talk of surgical clipping. Over to you, sir.
Thank you, Shiv Shankar. Is my slide visible? I'm visible and audible.
Yes, sir. You're visible, sir. We need to go to slide show mode.
Is it okay now?
Yeah, sir. It is seen, sir.
Well, thank you, Dr. Shiv Shankar, Dr. Dattatreya, the moderators and the panelists for the day, Professor Mishra, Professor Paritosh, and my co-panelists, Dr. Nitin and Dr. Kishore. I'm not sure whether it was meant to be a debate kind of webinar, but I guess I will take it as a debate because this is something very close to me. And of the two chairpersons, I know one, Professor Mishra, is definitely inclined towards surgery, whereas Paritosh, although he's a hybrid surgeon, I guess he has a slight inclination towards endovascular treatment. So please bear with me, Dr. Paritosh, because as I said, I have no disclosures, but I have a strong bias for surgical clipping, and I will shortly explain as to why. So that's why the title of my talk itself, I have just modified it a bit. Is surgical clipping the enduring gold standard for durability? It's beyond any doubt. Thank you, Shankar, because you gave a very specific topic about durability of aneurysm management, and I guess there is no doubt as to which is a better option as far as durability is concerned between clipping and coiling.
True, sir. Thank you.
Before I proceed, just to acknowledgements and admissions. The two reference articles which I have relied heavily upon for preparing this talk. One is by the chair one of the co-chairs for this meeting, Professor Mishra. Again, as I said, this is more inclined towards surgery. And to have a balance, I have taken this review with this common interventional neuroradiology, which again is a balance more towards endovascular management. So these are the acknowledgements through which I have prepared this talk. This is the age-old what we have been taught. The ISAT showed that almost 1.1% risk of annual rupture in completely occluded, whereas 5.9 in partially occluded one, and that is the CARET study, almost 13.3% of retreatment rates. And this is the BRAT final reports, which we all talk about. Approximately 1/5 of all coiled aneurysms may recur, and nearly half of them will undergo additional management. Now, this can be argued that this is an old data, and much revolution has happened in endovascular management, and things are much refined. I do agree to that, but we have this article which has been published as late as 2025, where we have microsurgical management of 883 previously coiled intracranial aneurysms. So this is definitely a problem. And if it were not so, we wouldn't be having this kind of classifications which kind of define as to how residual aneurysms occur, how they progress, and we have this hypothesis and the classification. These are the hypotheses as to how coil migration and coil impaction happens. So without any doubt, post-embolization residual or recurrent aneurysms, in fact, we have a nomenclature for that. PERA is a nomenclature for that. So this is a concern, so which I guess all endovascular surgeons would accept, that there is a definite risk of residual aneurysms which can regrow. Now, we do not have a similar nomenclature for aneurysms or residual aneurysms following surgical clip, but for the simple fact that because that is not a problem. And this is what one argument that the endovascular surgeon might say is that we do not have any study where surgery has been never questioned, and we do not have follow-up for surgical clip. The answer is no, because this is not a recent article, but a 2017 article which has studied the durability of aneurysm recurrence after microsurgical clip application, and you would find of 616 patients, only one recurred. And so that kind of emphasizes the durability or the completeness of occlusion of aneurysms following surgical clipping. This I am courtesy Professor Robert Spessler. This is a slide which I borrowed during his talk in 2016, and this kind of summarizes the available literature that was there in 2016, and this obviously shows that there is a risk of recurrence and regrowth and rebleed and retreatment following coiling, And he summarized his talk by saying that this certainly justifies another randomized trial. And this is on 2016. And do we have any randomized trials after that? Yes, we do have. Not too many randomized trials, but a couple or maybe 3 or 4 of them, but multiple meta-analysis and systematic reviews after that. And that is what I would be sharing. And first and foremost in my list would be this CURES study, the randomized control trial, the collaborative unruptured endovascular versus surgery trial, where the hypothesis was that clipping decreases the incidence of treatment failure from 15 to 14%, 13 to 4%. And this was a randomized trial, as I said. This is a flow chart, almost 143 in the surgery arm, 148 in the endovascular arm. The primary endpoint was failure of aneurysm, clipping, intracranial hemorrhage, or residual aneurysm. And if you see an overwhelming and a glaring outcome of the study was that this is the conclusion. I wouldn't go into the percentage, but definitely you can see that completeness of aneurysm occlusion was 80% in the surgical arm, whereas that was 57%. The same with residual aneurysms, residual necks, and fatal. And the primary outcome itself was biased more towards surgical clipping. And this is how they concluded, saying surgical clipping is more effective than endovascular treatment of unruptured aneurysms. As I said, I will just run through we have multiple number of meta-analysis and systematic reviews in the last, and I will restrict my sources to all the articles published in the last 10 years, preferably in the last 5 years. And this is the trial of patients who were missed out in previous trials. And again, you can see here, this is almost 270 patients from 2012 to 22. So I'm highlighting the fact that the recent ones, because these are the times when probably they have all adopted the newer innovations in endovascular treatment, including the flow diverters. And many of the studies, and not all, but many of them have included flow diverters also in their endovascular management group. And you can see the surgery versus endovascular, 8% to 20% is the difference between the in residual aneurysms at 1 year. Another study similarly, which uh, compares between coiling versus clipping, and this is a meta-analysis. Again, the results, and this is a huge number. You can't get better than this. Almost 100,000, more than 100,000 participants, and clipping demonstrated significantly high complete occlusion rates. So I will just go through multiple studies. I would just wanted to highlight that there are multiple studies, which this is in 2024, and most of them coming in the last 5 years. They conclude by saying that we speculate the surgical clipping may have a better outcome than endovascular coiling. This is another one in 2026, so as recent as 2026, which included one randomized trial and 3 observational cohorts of more than 500 patients, and they again concluded saying that clipping had an edge over coiling. And let me emphasize, this is all in terms of occlusion and durability of aneurysm closure, and not overall outcome, as I would talk about it later. So this is, now they have classified. We have anterior circulation aneurysms. We have meta-analysis for anterior communicating aneurysms. We have meta-analysis for small anterior communicating aneurysms, microsurgical for DACA aneurysms, for paraclinoid aneurysms, for pica aneurysms, and middle cerebral artery aneurysms. In fact, there are multiple meta-analysis, but what is interesting is that we are awaiting the results of this randomized trial, because middle cerebral artery aneurysms by convention were considered difficult for endovascular management and were more inclined towards surgical clipping. But we have a randomized control trial, the outcome of which is yet to be published, and probably we'll wait for a verdict upon MC aneurysms based on that. And this is about giant intracranial aneurysms, again basilar aneurysms. So I just wish to conclude this summary of all the meta-analysis and the randomized control trials which have happened in the last 5 to 10 years, because overwhelmingly they prove that as far as durability is concerned, clipping has a definite edge over coiling or endovascular management. Now, how do we define successful management of cerebral aneurysms? One, of course, is total occlusion of the aneurysm, and that, of course, decides on the risk of retreatment and the risk of recurrence and rebleed, recovery from deficits. That is, especially if it is a large thrombosed aneurysm which is causing, say, for example, an optic nerve problem or an oculomotor nerve problem. Complications which can be procedure related, complications which can be per se related to the bleed, subarachnoid hemorrhage like vasospasm or hydrocephalus. Good Rankin score at 6 months follow-up or later, need for survival, out-of-pocket expense, hidden costs, and so forth. So this is my analysis of how we would kind of summarize the outcome following management of cerebral aneurysms. And then this complications related to the procedure, complications related to the subarachnoid hemorrhage per se, which directly manifests as a good outcome. I must confess, definitely endovascular management has an edge. In all the studies which I showed, I must confess that I did not highlight that part of it because I was focused only on the total occlusion of the aneurysm. As far as complications and outcome are concerned, especially in the early stage, endovascular management has a definite edge. But as far as total occlusion of the aneurysm and risk of recurrence and rebleed and so are concerned, clipping surgery has a definite edge. But there are certain other factors which are never discussed, like the ones below, the need for surveillance, out-of-pocket expense, and hidden out-of-pocket expense. Of course, I would not discuss, because let us assume that everyone can afford all treatments. So these are some of the points which are seldom discussed, but am aptly highlighted in Professor Mishra's article. If vasospasm results due to blood in the cisterns, washing and clearing blood in the cisterns should reduce the risk of vasospasm. So definitely surgery should be a preferred option. Similarly, with hydrocephalus, if blocked cisterns secondary to bleed is a cause for hydrocephalus, opening the lamina terminalis, clearing the cistern should be a better option. Similarly, linear pressure effect on the nerves, definitely removing the thrombus should have an edge. Radiation effect, this is something which I'm really concerned about, because most of the juniors who nowadays use this randomly seldom take precaution. And this is not about the doctors. This is a study which compiles the radiation exposure to the patient. And this is the conclusion, most patients were exposed to levels of ionizing radiations that put them at considerable risk of deterministic radiation injury. Of course, risk of follow-up and the need for constant surveillance and the need for blood thinners, which again is variable because some give anticoagulants, some do not, some give double and dual antiplatelets. Of course, there are some guidelines, but there are some variations. So these are some of the added hidden costs which are seldom discussed when we discuss between coiling and clipping. So how do I decide and what is, so this is what we were taught earlier, and this was what's considered. Most of the aneurysms that are good for clipping are suitable for coiling too. But then of course, we have to decide, especially when we're in this era of hybrid neurosurgeons, who can do both clip and coil, they need to decide, and guess there are certain criteria, but these are some of the aneurysms some of the criteria which I wish to highlight. If there is a definite clot, it makes sense to decompress the clot. And when you decompress the clot, you might as well clip the aneurysm. Associated clots is definitely an indication. Then you have distal aneurysms like DACA. When the vessel is in spasm, definitely cannulation of these vessels might be difficult. So definitely surgery is the answer. You have this fusiform and distal aneurysms like this, where you might have to sacrifice the vessel. And this is one case where I had to do an anastomosis before trapping and floating the vessel. This is another case of fenestrated and basilar trunk aneurysm with multiple aneurysms, and this again was difficult to manage endovascularly, and these are again operated by me, and we had to clip aneurysms. This is a giant thrombose part, but there's a small flowing part. This is again difficult. This is multi-lobe aneurysm, where you might struggle putting in a coil and you might end up with the flow diverter and so forth. Multiple aneurysms in close proximity. I'm sure newer gadgets might make endovascular option easy, but I guess surgery is a better option in such situations. This is a video which I guess might not be of much relevance in this discussion. This is a lenticulostriate aneurysm, again difficult. A small young boy with a lenticulostriate artery aneurysm. You can see it over here, which is a small aneurysm over there, which again is very difficult to cannulate and manage endovascularly. This is a video of the same aneurysm, which again, I think not sure about the time. I think I'm over, shooting the time, so I'll just clip the video because I just wanted to show some of the surgically manageable aneurysms which are difficult to manage endovascularly, especially again when atherosclerotic vessels and difficult cannulation. This is a case of traumatic pseudoaneurysm where we had to do of course, a flow diverter in this current era would be an option, but high flow bypass with trapping of the vessel is an equally good option. Similarly, small blebs and blister aneurysms, now again, they all end up getting flow diverters. Managing them surgically is an equally challenging option, but this was one case where I did a wrapping and cotton wrapping of the aneurysm along with a fenestrated clip. So to summarize, I would just summarize by showing that this editorial review, which was published in 2025, which kind of gives us an guideline as to how to choose. If you have a young patient less than 50, of course, surgery makes a better option because the less risk of prolonged surveillance, less risk of dual antiplates, and so forth. Comorbidities, of course, endovascular has an edge. A ruptured aneurysm, it's plus minus, but if there's a clot, it is more in favor of surgical management. Unruptured, it is equipoise. Small aneurysms, again, this chart shows that it is more in favor of surgical management. Aneurysm location-wise, again, as I said, it is a controversial area nowadays with endovascular. Almost all aneurysms are managed endovascularly, but then, of course, cavernous, clinoidal, basilar, posterior circulation aneurysm tend to get coiled or endovascularly managed, and the anterior circulation are preferably managed through surgical management. And of course, if there's a hematoma or cranial neuropathy where we have to decompress the nerve, surgery should be the first consideration. Let me summarize by highlighting that aneurysm treatment needs to be for life, and that should be the prime consideration when you choose upon what line to adopt. Thank you so much.
Thank you very much, sir. It was really a great learning for us with a lot of facts and figures you showed us. And we have grown up seeing you operating on aneurysms. And I clearly remember that you used to tell us that the aneurysm surgery used to the perforators. So when you used to sever the perforates, there was no doubt about a residual neck or anything in those cases. And in all our 3 years of residency, we never saw any residual aneurysm being operated at our own institute because we are known for the neurovascular surgeries. So, but somehow there are because in the endovascular era, in Chitra also, as I understand from my juniors now, the number of aneurysms clipping has come down significantly. So the exposure to them has come down, and many are not interested to pursue this career in neurovascular surgery. Sir, but as you agree and we all agree, still there are many of the diseases wherein, in the neurovascular diseases, wherein the endovascular treatment has no answers or no definitive treatment. Wherein, as a neurosurgeon, we need to possess the skill and continue refining our skills in neurovascular surgery. And your talk and you as an inspiration will be a guiding light to many of those younger colleagues of mine who can learn and pursue and further excel in this art of challenging neurovascular surgery. So thank you very much, sir. It was quite informative. We'll hope to take the moderator and other panelists would love to take the questions at the end of the webinar, sir. So we'll continue with the discussions in the end of it. And thank you very much, sir. So next we have Dr. Nitin with us. Dr. Nitin? Dr. Nitin Dange? No, he was supposed to be the second speaker. I had called him before the start of the webinar, sir. Not finding him, is logged in. So, Kishore, sir. Dr.
Yeah.
Kishore?
Yeah.
Sir, Dr. Nitin is not answering. So, can we take up your talk now, sir? I'll just call him up. I had called him just before the starting of the webinar also.
Try him anyway, and then if he doesn't answer.
Yes, sir. Just give me a couple of minutes.
Yeah, sure.
Yeah, because I think yours will be good talk if we take it at the end, sir.
Probably, yeah.
Yes.
I'm also surgically biased, you know.
So some of the indications which I did show were the giant complex ones which Shivshankar was mentioning, where bypass needs to be performed. So
yeah, can you start presenting yourself? You can share your slides. Yes, we're just waiting. Yeah. Yes, thank you. We'll welcome Dr. Nitin Dange, who is a senior consultant neurosurgeon working in Mumbai and KM Hospital and also in private hospitals. So he is going to say about his experience in endoscopic coiling and beyond. Dr. Nitin? Hello? Dr. Nitin? He's online, but we are not audible. Dr. Nitin, are you audible?
Hello?
Yeah. Your voice is not clear. You're not audible. You're not audible properly. Yeah,
Now?
can you share your slides, sir?
It might be worthwhile taking the earphones out, Nitin.
Yeah.
So, meanwhile, can we ask some questions if we have time? Ask questions.
Shankar, as you said, what I wanted to
Yes,
maybe thought I might discuss
Hello?
in later
yes, sir.
was the lack of opportunities for youngsters to learn clipping.
Yes, sir.
And they're all biased towards endovascular. That's right, because that's a welcome and as I showed, the complication rates are much lesser. Outcome in the short term is definitely good. But what is worrying is the kind of training they have before they embark upon that. So many of them do a couple of angiograms and then end up start coiling, and with the help of all this company guys.
Yes, sir.
So
They bring
in
a
fact,
proctor.
they guide them as to how to use, and many of them, that's where you have this higher number of residual aneurysms, and so
Yes.
of course endovascular is
Mm-hmm.
a definite option, but the kind of training that is required for them is now being kind of bypassed. People end up taking up endovascular coiling after just performing a few diagnostic angiograms, and then all of them become endovascular surgeons.
Surgeons. True,
That
sir.
is something which we need to be worried about,
Yes, sir.
because as a resident, surgical as a surgeon, aneurysm clipping would be probably the last. Yeah, I think Nitin is ready. I guess I'll stop.
Dr. Nitin? But at the same time, sir, I think still slides are not shared.
One second.
Are you ready? Dr. Giri, sir. Sir, as you truly told, sir, like when we were residents, we used to see a lot of aneurysms, and we were encouraged, and we want to take up the challenge, and felt that we should operate aneurysm cases. But nowadays, the youngsters don't have the opportunity even to see the aneurysm surgeries being done, sir. So most of them, they don't have much of interest to pursue. And when the patients come, because I practice in a periphery, and I have a lot of colleagues with me, so they prefer sending them to someone and get the surgery done, and the patient will be shifted back to the hospital again. So this is how the patients are being managed. And the endoscopy surgeons in our region, there is no full-time endoscopy surgeon. Somebody comes from Mumbai or Pune, and they do, and they go off. So in that way, the many neurosurgeons, they are not pursuing themselves in neurovascular surgery, and even the training in training institutes, because of the lesser number of the surgery, has significantly decreased. So many of the younger colleagues are inclined towards endovascular, and they feel that since it is less invasive, less complications, it is better. But nobody talks about, as you told, sir, the residual aneurysm is never a topic to be discussed in our neurovascular and neurovascular surgery, but it is a common topic to be discussed in endovascular surgery.
I think Nitin is ready as well.
Yes. Dr. Nitin, can you start your presentation? Your slides are visual, sir.
I think you are muted.
Dr. Nitin, you have to unmute yourself.
Okay, can you hear me now?
Yeah, you're audible. Just
So, good evening, all, and thank you for this opportunity. I've heard the talk definitely, but let me continue with my views about what I've been told to talk. So, let me run through the slides so that maybe we'll get convinced what is we are doing today as hybrid neurosurgeons, and as Dr. Shiv Shankar was just mentioning, the younger colleagues would definitely like to know both sides of the story and would like to learn and would be happy to go ahead with both the things. But unfortunately, since the clipping, whatever way we used to do earlier, has gone down in numbers, the exposure to these colleagues or junior colleagues would always be a challenge. And the less the exposure, as we all know, the issues would be always having a confidence, and more is the patient's demand for endovascular, having lots of ISAT follow-ups and data. So people are more promoted for endovascular. So I'll rush through what I would like to say about the new generation endovascular treatment for bifurcation aneurysms and beyond coiling. So tailor-made integrated approach, that's what very important for us. Depending on the characteristics of the aneurysm, we will not generalized treatment for every patient should be every aneurysm should be clipped or either it should be coiled. So we would definitely select the patients depending on multiple criterias, apart from the patient criterias, apart from the other logistic criterias, aneurysm size, location, patient age, and comorbidities. The patient factors we always consider into age, clinical condition, then aneurysm factor, size, location, morphology, and institutional expertise. This is also an important thing which decides today which patients are going to go for what type of modality of treatment. So having said so, the core principle would be creating a stable construct in endovascular intervention, having a durable outcomes, so balancing coagulation, promoting endothelialization, and different methods of doing so. So it's very, very important. This is what approaches which has been evolving day by day as against the techniques would evolve in clipping, but what about the technology apart from some ICG or better views? The problem with clipping during the clipping the perforators and what advancement clipping is having today for complex aneurysm, we still lag behind parallelly as compared to endovascular technology, which is moving very, very fast. So having said so, for discussion, I have separated these types of aneurysms like the complex aneurysm where simple coiling. For complex aneurysms, there would be large giant aneurysms where stent assisted, balloon assisted, and flow diverters, which has changed the paradigm today. And definitely, it is one of the revolutionary treatment, I would say, while we were clipping and now many of this complex aneurysm which undergoes stent, that is flow diverters, especially the complex one with having very wide neck, giant ones, dissecting ones, as well as what we call blister aneurysm. Then wide neck bifurcation aneurysm is another boon which we are now having with intrasaccular devices. The challenging situations with ruptured aneurysm, which is more common with us, definitely the double antiplatelets is an issue, but we believe that ruptured aneurysm SAH is a procoagulation situation or a procoagulation state. So our expertise, our experience shows that in spite of dual antiplatelets, if you secure the aneurysm, the risk of rebleeding is almost negligible. So to overcome this, the fusiform aneurysms, definitely flow diverters is one of the best options even today. Then other aneurysms like infection, aneurysms, coiling, liquid embolic agents, stent-assisted flow diverters, and adhesives like low vascular true fill and NPCA agents, wherein we go for a PVO, parent vessel occlusion. Then comes the dissected aneurysm. Definitely stenting is the treatment of choice rather than the coil, what we call clipping, where dissecting aneurysms is always a challenge we all know. So traditional endovascular options and limitation, wherein we do balloon assisted coiling, as we all know, in wide neck, in spite of taking a support at that, we would definitely like to cover the neck so that the recurrence what we are having today is because of the neck being not covered completely by the coil mass and some endo leak is there which can keep a residual neck and would be an important factor for regrowth at a later date. So stent assisted coiling in bifurcation aneurysms always was a earlier an option where we needed double antiplatelets was a challenge, then lots of hardware, but we could secure the aneurysms and occlude it if we used to use wire stenting and all. But the availability of intrasaccular devices has made things very, very easy. Before the intrasaccular devices, we still used to use flow diverter and coiling in bifurcation aneurysm. Though we were jailing one of the branches, we used to see that the artery used to remodel. They were not an issue about jailing or covering the other branch, and there were no infarcts, but aneurysm definitely used to reduce, and we had a success rate. We still have a success rate of follow-up in flow diverters about 92 to 94%, which is a very significant high success rate in long-term follow-up. In spite of ruptured aneurysms, we giving double antiplatelets as compared to the complex aneurysm which we used to clip in the earlier era. So our concept of intrasaccular devices, which are ruptured ones at the bifurcation, where you can see here, this is the Sano's concept where the aneurysm origin is from the intima, and he usually puts perpendicular clips rather than we conventionally clip the aneurysms at parallel to the branches of the vessels. Here, the aneurysm origin is what we see in the intima. So we started using the intrasaccular devices when it was available for us for ruptured aneurysm. And these were the game changers for bifurcation wide neck aneurysms because it was very easy to deploy, easy to what we call position. And our concept was to bring the device much, much inside the parent vessel so that there is no thromboembolism, but the endoleak stops, and we used to cover with antiplatelet only during the procedure, so that if there is a thrombosis or if the aneurysm, the device comes into the parent vessel, we may put a additional stent and cover and keep the vessel, all the three bifurcation vessels patent. So next generation intrasaccular devices which we are having today, and every day new device is going to come, and every month we are seeing that newer and newer intrasaccular devices are coming which overcome the previous data or previous publications, where previous trials and follow-up studies which are about 3 to 4 years now, whatever we have achieved, the success rate for this complex ruptured bifurcation aneurysm is about 88% to 90%, which is a very good what we call cure rates which we are achieving, and there is no rebleeds in any of these study. So this was Medina, which was intrasaccular devices. I'll just rush through for want of time. Then Luna, which were earlier available. Then comes the Artist, which is lately been launched in India last month. And this is another promising intrasaccular devices. You can see the implantation success and complete occlusion rate is about 80% at 6 months to 1 year. Now we have a follow-up of 1.5 years. Then comes Nautilus intrasaccular devices. This was another one, a previous generation. The new generation is yet to get available for us. Then next stent with coils, wherein we had a support at the neck and we could coil through the stent and achieve good occlusion. Then kept the web, which is almost available with us for last 8 to 10, 9 years now. And we have a follow-up of about 8 years average, wherein the success rate is about complete occlusion rate is about 85%, and I would say what we call the cure rate is about 90%. So then we launched this Contour device in 2019, which was first of its kind in our country, and for ruptured aneurysm in Asia, we launched this device, and we have a follow-up of about 80 patients now, and the mean follow-up is 4 years, wherein there was no rebleed in any of these patients, and the success rate in our series is about 92%. So these were all complex, ruptured, wide neck bifurcation aneurysms, wherein we use this double layer contour intrasaccular devices, and it's our own experience, which I'm just coming to, having a good success rate. Seal has been just launched in India. It has been used in US and Europe for last 1.5 years. We still need a long-term follow-up of this device, but this also looks very promising for intrasaccular devices. Just to show some interesting cases where this is about the contour, wherein we detach this device, putting up way into the parent vessel, and this is how we prevent the endo leak by pulling it back into the neck of the aneurysm, preserving the perforators as well as the branches, and then detaching. So, for want of time, I just rush through the cases. So, endovascular intervention, definitely for saccular, complex, saccular simple aneurysm with narrow neck, simple coiling, large giant aneurysm, stent assisted, wide neck, we have intrasaccular devices. So these were the some of our representative cases. This was the first case which we did way back in 2019. The patient was not ready for open surgery in spite of there being a large hematoma in the right temporal region through this ugly looking blister. There were two blisters on this not giant, the large aneurysm at the bifurcation with wide neck. So we offered them clipping. They were absolutely not ready. So the contour was available. We offered them this contour. This was the first case, so we didn't take a risk. We put some additional coils and we deployed coils and the contour, and we have the follow-up of this patient of now 5.5 years, and she is doing very well, excellent. So this is what we published, our initial experience in 2022, about 18 cases of contour ruptured wide neck bifurcation aneurysm with a success rate of a follow-up of about 2 years with a success rate of about 88 to 90%. Then comes the web. These are some of our representative cases. 47-year female with ruptured GCS 14/15, shows bilateral subarachnoid hemorrhage, and there was a ACOM aneurysm here. So this was a regrowth of the ACOM aneurysm, and we put an additional web into this regrown ACOM, and we have a follow-up of. So this is another aneurysm, which is a bifurcation wide neck aneurysm of the MCA, which we use the web, and you can see here it's a very straightforward. The standard hardwares which we use is the long sheath, then the intermediate sheath, and then the microcatheter and a wire to cannulate the aneurysm. So this is the video, which is a representative video wherein very straightforward we can deploy an intrasaccular device, detach there, and immediately there is a stasis into the aneurysm, and at follow-up we see that aneurysm completely disappears if you are deployed it well and secured the neck properly. That is very, very important, and the philosophy has to be understood of this wide neck intrasaccular devices for wide neck aneurysm. Then another representative case, 32-year-old with right MCA bifurcation aneurysm, wherein we have used a large web and repositioning this. Then we usually follow up with a rotational, what we call vaso CT, so to see the deployment as well as the stasis and positioning of the device. This technology is very, very important. Not many people use it, so it is under deployed or not positioned properly, and that's why we get recurrences. So it's very, very important to use and understand the philosophy. Now you can see here, this is a very ugly looking wide neck bifurcation aneurysm, wherein we use the contour, and we always have worries about what is going to happen to the perforators, especially when you are clipping or doing a flow diverter. So this helps us to position the device very well, and you can see their immediate stasis and very well conform. The name itself says that it is contour, so it takes the shape of the neck from within, saving the perforators by seeing all the branches in vasosity and position of the device does make a difference to have long-term good outcomes. So for want of time, I'll rush through few of our cases of flow diverters wherein it is used for side walled aneurysm, not the bifurcation aneurysm, especially which are having complex anatomy like wide neck, fusiform, blisters, and incorporating the perforators. Now, when we were talking of clipping, what we were thinking of is always giant aneurysm, complex aneurysm, wide neck aneurysm. Usually there are perforators which we don't worry when we do the flow diverters because they never get occluded. Even in delayed follow-up, if their flow is slow, the collaterals take over and the long-term follow-up is fantastic with complete occlusion of the aneurysms, preservation of the parent vessel as well as the perforators. So this is where the side wall aneurysm classically indicated for flow diverter, wherein we don't have to really do a high work of open conventional surgery, drilling of the anterior clinoid, having too much of a stress at the supraclinoid location. Just a simple flow diverter, and you can see here these are representative steps. For want of time, I'm not running through the videos, and you can see here once you deploy, the follow-up of these is fantastic. You cannot even realize that there was an aneurysm, and the artery remodels, the perforators and the branches are well preserved, and there is no recurrent.
You are not audible, Dr. Nitin.
Hello?
Yeah, you are not audible actually. So we have a couple of more minutes because you have one more talk waiting for Dr. Chaudhary.
Yes.
So can you just finish off in 2 minutes, sir?
Yes, yes.
Yeah.
Can you hear me now?
Pardon?
Can you hear me now?
Yeah, you're audible now.
Okay.
Yes.
So just rush through for want of time. This is an ACOM artery aneurysm which is ruptured. We have when initially we just do a simple coiling because it was wide. Then and coming for follow-up, and the aneurysm is to
There's an issue with the voice. You're not audible. Hello. Dr. Nitin, you are not audible. Can we conclude and end it?
Okay.
It was quite, yeah, now it's okay. Yes.
Now you can hear?
Yeah, you're audible now. In between, absolutely you're not audible.
So basically, the literature wherein endovascular flow disruption, endovascular flow diverters, as well as intrasaccular device is now the data is overwhelming. It is very promising, and we need definitely long-term follow-up for intrasaccular devices. But flow diverters has proven test of time, and there are success rate has been in all the data about 92 to 93% in complex aneurysms for side wall. For want of time, these are our references. I said follow up. We all know. So rapidly evolving field of neurovascular surgery has significantly what we call enhanced the ability to treat many complex aneurysm with high aneurysm occlusion and low recurrences. Neurosurgeons must understand core principle of endovascular aneurysm intervention and analyze patients and aneurysm specific information to create safe, effective, and long-term durable constructs so that recurrence rate, which is one of the concern in endovascular follow-up, will be reduced or maybe negligible. Thank you.
Yeah, thank you very much, Dr. Nitin Dange, sir. It was great listening to you all the time. being a neurosurgeon, what you showed was something different for the neurosurgeons doing these cases, like even Professor Paritosh Pandey sir does. So as you clearly told that it has to be tailor-made, and we have to decide like when to coil and when to clip. And as a neurosurgeon, probably being an endovascular surgeon, you can make a greater decision without bias, because neurologists and radiologists, they have only one tool in their hand to coil it. So being a neurosurgeon, we have an upper hand, so that we can decide unbiased and just take a patient for clipping or whatever other procedure surgically you can plan. So you did a great justice to your topic. We'll take up the questions at the end, sir. Now,
Sure.
Chaudhary sir will talk about the end topic, which is quite interesting, and we are all awaited to listen to him. That is beyond clipper coil, the multidisciplinary decision making in the aneurysm surgery. He has to talk about both the clipping and coiling and what exactly is being followed in UK. He works in Suffield. So probably the protocols and things are more organized and structured in UK. So we'd love to hear from you, Dr. Kishore Chaudhary, sir.
Hello, good evening.
Good evening,
yeah,
sir.
good evening to you all. Can you see my
Yes, you are seen, sir.
my
You're audible.
slides, right?
Yes.
And you can see my screen as well?
Yes, you're seen, sir.
And why can't I see? 1 second. Okay, so I'm in a slightly different setting, and in a way, it is good because I can give a different perspective. In a way, it's bad because not what all I say is relevant to the Indian setting. So you have to take everything what I say with a pinch of salt. Thank you, Shivashankar, for inviting me. Although I'm the webinar chairman, I don't interfere in the organization of the webinars. And thank you. I very much appreciate you inviting me with Girish and Nitin.
Thank you, sir.
And yeah, both of them have been excellent talks and so much research laden and convincing that it is a difficult task to say what I'm going to say. Now, I'm at a disadvantage that we don't have anyone like Nitin Dange or Paritosh Pandey in our department. We don't have a hybrid neurosurgeon, which is a loss. But that's why we have to adopt a hybrid approach. And that's what we do, I'm going to tell you. I work as a vascular neurosurgeon in Sheffield, which is a tertiary referral center. And what I'm going to talk about is just what our multidisciplinary team approach is. How do we go about managing aneurysms? This is our workload at STH, that is Sheffield Teaching Hospitals. We have 150 aneurysmal subarachnoid hemorrhage per year and about 400 unruptured aneurysms referred to us per year. We are 3 vascular neurosurgeons out of 18, and we have got a five interventionalists who do coiling and thrombectomy service. Plus, we got fellows, we got vascular nurses, ICU bed, HDU beds, ward beds, physiotherapy, occupational therapy, and a dedicated neuro rehab unit. So we are quite well equipped, I must say. These are the to put it simply, there are 2 management pathways of cerebral aneurysms. Acute subarachnoid hemorrhage, we manage them under the care of on-call neurosurgeon, not vascular neurosurgeon, with input from on-call radiologist and on-call vascular neurosurgeon. If they need any intervention, they are taken up by a radiologist or a neurosurgeon. For elective cases, we have completely different channel. We channelize them through our weekly neurovascular multidisciplinary team meeting, which I'm going to talk about. Because there is so much volume of 150 subarachnoid and about 400 unruptured aneurysms, it is impossible for one person to be responsible to make the decisions all the time. We have to have a team approach. Well, individual aim in the aneurysm is, you'll all agree, to obliterate the aneurysm completely, to prevent recurrence and prevent rebleed, and to prolong lifespan, improve the MRS, and maintain quality of life. There is no doubt about it. This is what is natural history of the subarachnoid hemorrhage patient in the UK. 1/3, that is 33% patients, do not survive to reach the hospital or to have a definitive treatment. 1/3 do survive, they're treated, but they never reach their pre-morbid status again. And it's only 1/3, that is about 30%, who survive, get treated, recover, and back to usual themselves as they were before subarachnoid hemorrhage. And that is all countrywide stats in the UK. So actually, for me, as a senior neurosurgeon in the department, the aims of treatment of subarachnoid hemorrhage does not stop at individual excellence or individual case. My aim for our department is to alter the natural history of the disease over a prolonged period of time. When I say prolonged period is 5 years, 10 years, 15 years, 20 years, or 25 years. And the second aim is to promote learning, training, and pass on the skills and experience to our juniors so that they can shift the natural history to the betterment of the patient. In other words, just going back, I would like this 33% to go into this second group and this second group to go into the third group. So in other words, my aim of treatment is not only individual excellence. My aim of treatment is to get more and more patients to survive, get them treated, and back to the usual themselves. And I'm aiming for 40 or 50%, which is very optimistic task. But with the help of our INR colleagues, it is getting more and more possible and realistic. These are the options that we have for subarachnoid hemorrhage. Endovascular treatment early, and so or a surgical clipping early, 48 hours. Just to give statistics, about 138 or something subarachnoid hemorrhage admitted in the last 1 year. We treated all of them 100% within 48 hours of ictus, which I'm very proud of. We also do masterly inactivity, especially in elderly patients or those with significant comorbidities such as cancers. Because remember, 25 to 30% of the patients who have had aneurysmal subarachnoid hemorrhage do not ever bleed again. So if we cannot offer treatment that is less than 20% risk of morbidity and mortality, probably inactivity or not doing anything or taking chances of re-rupture is a better option for them than treating them in my hands or my colleagues' hands. And for grade 5 subarachnoid hemorrhages, we are very aggressive. We wait, we support, and review them every weekly or every few days and treat them either by endovascular means or surgical means. This is what the benefit is between cooperation between surgeon and interventional radiologist, INRs. We can afford to have more aggressive treatment of grade 4-5 subarachnoid hemorrhage. We nowadays have dual consenting process. So patient has a DSA and a GA, and then we already consent in the patient to coil or to clip. We explain them the risk of both and what should they expect when they wake up. And that works very well because many a times our interventional colleagues are not completely sure whether it's a coilable aneurysm or not. If patients needs demand coiling as the first choice, we give them first choice of the DSA, but with a proviso that they could come back to say that, look, we have done the DSA, we don't think we should go ahead with coiling, we take them to theater and clip them. Third thing is, for recurrent aneurysms after coiling, which does happen, we have a very good joint agreement about what the best way should be. And it works very well if we discuss them between each other. Because recoiling is always an option, newer techniques like flow diversion is option, and surgery is also an option. And lastly, sometimes in poor grade patients, we prefer just coiling of the dome so that let them recover and we can revisit the consequences after that, if and when patient improve. For recurrent aneurysms, it has been very helpful to have our INR colleagues. For example, this is a MCA aneurysm that was coiled after subarachnoid hemorrhage, has recurred. This is right MCA. This is one M2, that's other M2. And you can see this aneurysm could have been coiled again. But our INR said that if we do coil them and it recurs again, there will not be any neck left for clipping. So we went ahead and clipped this at the insistence of our interventional colleagues. Same thing, anterocommunicating artery aneurysm, had coiling done and and had grade 1 subarachnoid hemorrhage about 4 years later. Our INRs could have coiled this aneurysm, but because there was a doubt about this another blister aneurysm, and because there was a reasonable neck and the blood load was very minimal, they pushed us to do clipping, which was very easy, very straightforward. And so I'm just going to discuss about what MDT means and where does this model come from, or what the meeting is for, how it runs at our department, what the evidence is that MDT is supported and what it does not, what are the advantages, how do and why do MDTs fail, and the relevance in Indian setting, if I get a chance. So this is the scope of our MDT. We discuss ruptured, unruptured aneurysm, recurrent aneurysms, AVMs, dural fistulas, spinal AV malformations, moya, and other diseases. We discuss our agreement about treatment, disagreement, and the best pathway. It's quite a workload. These are the members of our MDT at STH, that's Sheffield Teaching Hospitals. Vascular neurosurgeons, interventional radiologists, vascular neurologists, fellows, trainees, registrars, vascular nurses, observers, visitors that we quite have, and secretarial and admin staff. Usually, in our department, we have a roundtable in person or on MS Teams meetings weekly, 9 to 12, every Friday, chaired by a vascular neurosurgeon, either me or one of my 2 colleagues. Cases are already populated by vascular secretary. They are presented by usually the fellow or the consultant. There is a real-time recording and dictation of outcomes. If it's on Teams, it's automatically recorded. And then we triage patients regarding how urgent they are, should they be transferred immediately or semi-urgent or on an elective basis. Now, is there any evidence that multidisciplinary team management works? So there is some evidence that is reasonably well supported and some that is not yet established. What is well supported is that MDT review does change management plan in a meaningful minority of cases. Most of the times, we all are clinicians, experienced clinicians. We know what should be done, but MDT review helps. Secondly, there is concordance with guidelines and protocols, which we have a lot of them in the UK and in NHS, and that improves. Thirdly, documentation becomes easier. Data set completeness also improve. What I mean is patients' demographics, pre-morbid history, etc. And lastly, recruitment into trials and registries also increase. And this is well supported that MDTs do facilitate that. What is not yet established is that, is there any survival benefit that is attributable to our meetings, consensus meeting at all? Or does the improved survival come from comes from centralization, a huge volume of cases that we have, and a subspecialization within our team that we follow? So it's not clear. There is no proof. Also, there is no proof that the larger meetings produce better decisions. We would think so, but I'm not sure. There is no evidence. Also, there is no evidence that the consensus in the room tracks correctness. So what I mean is, if we all agree to a decision, doesn't mean that's necessarily a right decision. And lastly, I'm not sure whether it is cost effective at the current length and staffing of the meeting. And that's very, very true for all settings, whether in India or here. This is the timeline of our MDT meeting. Before we prepare, we review them cases. In the room, we present, we discuss, then an output is recorded, a decision is made, and afterwards, all the outcomes are returned, such as complications, retreatments, rebleeds, etc., at a later stage. We have about 400 to 500 aneurysms, unruptured aneurysms referred to us every year. That's a huge number. The decision is a comparison between 2 risks over lifetime: rupture if untreated and harm from treatment. Every patient is different. We do take into account the ISUA phases and UH trials, but where these trials stop is none of these studies consider the experience of the operator, the policies of that unit and available expertise in that unit, or the patient's tolerance of a known risk that is carried for decades. and their preferences. Now, that is the work that is left for the MDT, and we discuss that, not only the morphology of the aneurysm. I'm going to talk about some benefits of decision making. So I'm going to divide into three parts. One is clinical benefits, some administrative benefits, some medical legal advantages of our MDTs. Our MDT supports management of complex cases. That goes without saying. If you got more than one or two or three neurosurgeons with expertise in vascular neurosurgery and 4 or 5 out of interventional radiologists sitting there, we can easily deal with complex cases. These MDTs, they bring together different professional expertise. Neurosurgeons, neuroradiologists, fellows, and overseas visitors as well. They provide a holistic view of the patient. Decisions consider the patient's physical, psychological, social, functional needs rather than focusing only on the medical condition and comorbidities or morphology of the aneurysm. These MDTs improve patient safety. Multiple professionals can identify various potential risks, contraindications, safeguarding concerns, or gaps in the care that one clinician might overlook. These MDTs also support evidence-based decision-making. As I realized from Girish Menon's and Nitin Dange's talk, that it is impossible for me to keep a tab on recent advances on both clipping and coiling. So the team members in our department can contribute current clinical knowledge, guidelines, research evidence, their own professional experience to reach an informed decision. The MDTs, they reduce errors and bias. Discussing cases collectively provides opportunity to challenge assumptions and identify alternative diagnosis or treatment options. For example, I am under impression that MC aneurysm should always be coiled. That's not true, actually. They can, should be clipped. That's not true. Nowadays, they can be coiled. So that is one of the bias that I have. The MDTs also improve coordination and communication. There are some administrative advantages. Continuity of care, shared care plan, documentation makes better use of resources, facilitate early identification of problems, and promotes CPD. There is also an excellent teaching tool for juniors and nurses. But the main part that is relevant to you guys as well is medical legal. These MDTs and joint discussions, they strengthen accountability within the group, enables seamless record keeping, and the most important part, that these MDTs, they dilute individual medical responsibility. They shift the liability from an individual clinician towards share or institution so that our liability, if something goes wrong, is minimized. Well, our MDTs are not without flaws as well. So these are the known failure modes. Rubber stamping. The volume is so much. We just like to go it one by one. So we don't give more than a minute per case. And that's because of the sheer volume we have. Dominant voice. We all are strong personalities. I'd like myself to be heard more. If I'm senior, then my voice is louder. Well, there are always countermeasures for all this. Missing information. So much volume, sometimes there is no angiography, no comorbidity data, and there is a risk of making wrong decisions. The patient is not present in the MDT, so patient's own preference and risk tolerance are inferred. They are not taken into consideration when we make the decision. Then that's why there's also a decision drift. What it means is we decide something in the MDT, but the treatment modality changes in the clinic or even in theater when we know what the patient preferences are. And then lastly, there is no feedback loop. We have so much of volume that the outcomes never come back to the deciders. We cannot afford to spend time on complications or even the acute cases to be brought back, which is a disadvantage. There is always disagreements, concordance, and discordance. And we can always reimage, we can always state risk and our experience. We can always, when the evidence is genuinely balanced, we can always give both options to the patients and the patient can decide. Sometimes we can take an external opinion as well. Even I give external opinions to the other MDTs. And lastly, we do record all the disagreements in the minute. We are all different individuals with different preferences and different experiences. and expertises. So yes, disagreement is a common thing. In India, this is a talk for discussion, so I'm not going to dwell more on it. How can we have MDTs and what can we do, especially in the central institutes and the teaching medical colleges? I think my point is very valid, that it has to do, a lot of it to do with the mindset about patient ownership. But we can discuss that later. This is a picture, actually, it's a video. I'm not going to show the video because this is where I'm supervising for 4 hours and a fellow is operating, a senior registrar is assisting, and I'm actually scrub, but not interfering with the clipping of aneurysm. That's how we train, not just when the dura is open, coming and doing the job yourself. Sorry. So in conclusion, in our experience, neurovascular MDT decision making supports safer, more holistic, patient-centered, coordinated decision making, which is important, where patients often have complex needs and multiple professionals involved in their care. And I think the way forward is the MDT discussions and coordination between both the vascular neurosurgeons and the interventional neurologist. Thank you very much. And sorry if I was too administrative and not clinical in my discussion.
No, thank you, sir. Thank you. It's quite a wonderful talk. And this is what we wanted to learn from you. Because in India, so much of structured and protocoled things we are not probably following, or I am not aware of these things. So since you are in UK, and it is really great to see that how a team can come together and do a greater justice to the patient. And for you, there is no financial worries actually. So we need to consider a lot of things when we are working in India. But we could learn many things unbiased. How can we decide for clipping or coiling, not as an individual, but as a team? So thank you, sir. Thank you. I think it's almost 9:45. We have less time left for discussion. So we have Professor B.K. Mishra, sir, with us and Dr. Paritosh Pandey, sir. So the topic is open for discussion, sir. Paritosh, sir.
Sir is there, sir. Sir was there.
B.K. Mishra, sir. Mishra, sir.
Sir, mute, sir. Okay, fine. I'll say. Okay, I will say. So thank you everybody for these the wonderful talks. I just noted down a few things which I would like to say. One is the first thing is, what is the outcome that we are measuring? If the outcome that we are measuring is angiographic occlusion, then there is absolutely no doubt that clipping is the best way to go. But unfortunately, the other two outcomes are there is number one, rebleed prevention, and number two, safety of treatment. The safety of treatment, at least the short-term safety of treatment, everybody agrees that endovascular treatment is the better thing, and that is probably what the patients want. What the doctors want and what the patients want is a completely different paradigm. Patient wants to have less complication after surgery. So that is why 80% of cases in Western countries are now being coiled. The third thing also is the rebleed prevention. So though the rebleeds are more in the endovascular group, they're not remarkably more. So even if 20% of them recur, the number of aneurysms that rebleed is very low. And add to it that there is a fair amount of safety of retreatment, the rebleed rates even go lesser. So I completely agree that clipping is durable and it is permanent, but it comes at the cost of short-term higher degree of complications, which probably is not acceptable in this age and time for the patients. And what we are looking for, the primary outcome, and that is why primary outcome is always safety of the treatment. So it's a debate, but that is probably the reason why the pendulum is shifting towards the endovascular group, even though demonstrably the durability of this is better. Even with the new devices, there is residual neck in 10 to 20% of the patients, which Nitin showed very well. The other things that I would talk about is the patient's choice. The patient's choice, of course, is one of the most important things, and I was surprised that Dr. Kishore kept it very low down the spectrum. I mean, in our view, where we are, I'm counseling any patient, it is at very high level of thing. What is the patient's choice? And a lot of people do that. Dr. Girish also touched upon the less amount of clipping going around in with young neurosurgeons. I would probably disagree. 20 years back, there were a handful of neurosurgeons who did clipping of the aneurysms. Now you see every district has a patient as a doctor who is clipping aneurysms. So I don't think that number of young neurosurgeons who are clipping aneurysms are less. What has of course happened is that those young neurosurgeons are clipping less number of aneurysms as compared to say what Dr. Mishra or Dr. Mehta or other people were clipping. So number of aneurysms per surgeon has definitely come down, but I don't think number of clipping cases have gone down in India at least. That is probably my thing, and it is probably there. What should also happen is we should change in our curriculum, and we should try to think how neurosurgeons can get trained into these things at not even in their curriculum as well as post MCH. So that is number one. Two things I wanted to ask Dr. Kishore Chaudhary was that he said that most of their decisions is taken on CT angiogram, sorry, DSA. I mean, in at least in our practice or at least in other practices in India, most of the decision is taken on CT angiogram. So patients get a CT and CT angiogram, and then based on that, the decision is taken whether to roll the patients into the clipping, coiling group or clipping. Very rarely what happens is that at DSA, we understand that this is not possible and we clip the patient. And of course, the clipping group goes and gets clipped either ways. And the last thing I want to say is that I think this MDT is overdone, in my view, if we do it blanket MDT. So if we roll in all patients of vascular surgery or aneurysm surgery or something, and then do an MDT, then it probably becomes very meaningless. I think it is more of just more of auditing and data keeping rather than decision making. If we reserve it for complicated cases and do discuss two or three things rather than just discussing every case through an MDT, that probably dilutes the process of this whole thing. And that is my understanding of how things are done based on some things. But yeah, these are my observations regarding this. Thank you again for very, very good presentations.
Thank you, sir.
Sorry, can I just correct? Sorry, our decisions are also made on CT angiogram. Sometimes, whenever the interventionalists are not sure on the basis of CTA whether they would be able to coil or not, or treat interventionally, then we do a DSA and then take a call. So
Fair.
that is not a routine thing.
Fair enough. Yeah.
Okay, can I talk?
Yes, sir.
Yeah.
You're audible, sir.
Yeah. So I think I'm very delighted that all the talks are by neurosurgeons. So the endovascular talks are by neurosurgeons. This is a very, very welcome change, which from the time I have started learning neurosurgery, learning vascular surgery, and till about maybe 20 years back. I mean, so we have developed, and that's a very good sign. And I agree with Paritosh, the fact that the patient's choice should be the first choice, but all depends on who is talking. That is also very, very important. Just, I mean, don't mind the or underscore or don't give too much of importance only to the patient choice. I mean, who is talking, it makes also a difference. But absolutely, I agree completely with you that the short-term benefits are higher in endovascular treatment. There's no question about. And it's also true that more aneurysms are still being treated in India than probably anywhere in the world, except probably in China. Maybe in China, maybe they're treating it, but the the percentage of aneurysms which are still clipped in India is probably higher. Before I go on, I just want to ask Kishore, what's the incidence of your, I don't know whether I missed it or you didn't tell. What is the incidence of your clipping and endovascular treatment now in your,
Sorry,
department?
yeah, Basant, I didn't say because I didn't go into any figures, but I contributed a number of patients to ISAT because that's when I started consultancy. And I've been a big recruiter for ISAT. And when ISAT was published in 2002, Andy Molyneux and Richard Kerr, who were the co-author, I remember having a dinner with them. And they said, you're joining as a vascular neurosurgeon, but your job is finished. You've got no work to do. Because at that time, I was clipping 2 or 3 aneurysms per week. And now, 25 years down the line, I'm still clipping the same amount of aneurysms, if not ruptured aneurysms, elective aneurysms, or doing some other cases. So this fear that the surgical expertise will die down, I think Shivashankar had mentioned a few times, I think is a bit of a myth. It will not die down, but we have
Kishore,
also
I'll just interrupt here. I'll just interrupt here. It is definitely much less in UK. I mean, you are probably groups of people who are very few groups who are doing it, right?
that's true.
Compared to what it was being done, say maybe 30 years back, 40 years back.
Absolutely, yeah, yeah.
I went for my training. I mean, we all went to UK to learn aneurysm surgery, right? The register had to clip 10 aneurysms to be qualified to be senior register. So that's a logbook they had to, I am not sure how many centers are having that in UK
Um,
at least.
we clip about 20 to 25% aneurysms, Basant, acute aneurysms, roughly.
Yeah. So
Yeah,
that is in a probably in a referral center where you have a vascular group of people, specializing in that.
that's right. That's
That may not be the national average. Is that the national average now?
more or less that would be about 25% would be the national average.
So
Some
that's
units
very
clip
good. Actually,
more.
it's much better now than what it was about 20 years back. It
Yeah,
was
yeah.
5%. It was only
Oh,
5 to
yeah.
10% aneurysm.
No, no, it is more than that because number of units still clip, especially
No, no.
Cambridge.
I mean, after I sat, few years, the number of aneurysms which were microsurgery was less than 10% in UK.
Yeah, but that's because number of interventionalists now understand the limitations of
Yeah. Yeah,
interventional
that's what that is
cardiology.
exactly what I'm trying to tell. See,
Yes,
there is a learning process that many of these androgens probably are better by microsurgery. That is what I'm trying to get at. So that's
that's
what I
right.
was trying to see. The after the euphoria after the ISAT, has a little bit of that happens for everything. But my
That's
my
true.
point to make it here, why are we if everything was so good at every time? Why are we keep changing? I mean, it's a good thing to develop. There's no question about it. A good thing to improvise. But every time a new device came, that was the ultimate. Till the next device came, till that became the ultimate. Till the next device came. So obviously we have not. But how? What, on the other side, you have one clip, and that's it. You kill it. You kill it for good. I mean, of course, you need experience. You have higher morbidity. There's no question about it. But the technology, the procedure of clipping is remaining the same. There are, of course, advances as so many things. The bottom line is you block the aneurysm, right? So
That's right.
I mean, I will tell you I mean, many of you, I don't know, Kishore were there, but most of you were not there when 89, we had the vascular symposium in Trivandrum during the World Congress. I was in charge of the scientific program, and we had a debate between Dr. Spetzler and Dr. Jack Morey on endovascular treatment and microsurgical treatment. Jack Murray was brilliant. I mean, he was no question. He stole the show. But do you know what was he talking about that? That time was balloon occlusion of the aneurysm. You understand what I'm saying? So
Yeah, yeah.
that was a big hit. People got so excited.
Excited.
That
Yeah, yeah.
changes the thing. So
That's
the
right.
question is, you have to be realistic. In fact, tomorrow, yeah, I'm in a meeting in Dandy's meeting. Tomorrow. My talk is why aneurysm microsurgery should continue. That's my talk tomorrow. So I was listening to all your talks, and it was very very informative. I'm very happy about it. But I think my takeaway from this meeting, I'm very happy that all neurosurgeons are talking about this, number one. And number two, I think the way forward, which I was wrong, and I think Parithos and all his Nitin and these people have taken it forward, and I think probably the right way to do it. Having getting dual trend, which I was never a fan of dual trend. And let me admit that was my mistake.
No.
I never thought that is the right way to do, but on retrospect, I think in India at least that's the right way to do. Otherwise, the patients will not reach you. The patients will not reach you because the patient will reach a person when they know that this guy has both the expertise and he will take the right choice.
Absolutely. Yeah. Can I just mention one thing Paritosh mentioned about patient choice? You're right, Paritosh. It was not high on my agenda about patient choice because most patients, when they are ruptured or their families, here at least in our practice, do not understand. And what they say is that do whatever best you think we should do. And they leave the decision onto us. Now that's where our decision making has to be very robust because at that time we have to do what is best for the patient who's in acute dire state. For unruptured aneurysms or recurrent aneurysms, situation is slightly different. If there are unruptured aneurysm and can be treated by both means, we do offer them a choice, and many a times patients do select the choice. And that's true for AVMs as well. For radiosurgery or endovascular or surgery, we do give them a choice. But for acute cases, most of the times, a decision has been made for them, and we just take their approval.
But Kishore, I think
I,
we are completely different societies. So
That's
and
true.
the problem is completely different. Here, the patient comes pays for it, right? He demands a treatment, right?
That's
In your NHS, they are served by the nation. So the plus the what should I say, the suspicion that the doctor is taking them for a ride is much higher in India than in
yes,
UK. I
yes.
mean, having
That's
worked some
right.
time in UK, they trust you much more than they trust you here
Actually,
in India. I'm,
actually,
I'm, I'm telling you, absolutely, it's a fact.
Dr.
you are
Kishore,
so right, Basan. I'll tell you what. If I tell my patient that look, this is a complex aneurysm and I need to take a second opinion, sometimes they object to it. They don't understand why do you need a second opinion. And in India, it's exactly paradoxical. People don't get treated without a second opinion, and that's absolutely true.
Dr.
Because the
Kishore,
patient cohort and the system is different.
Dr. Kishore, correct me if I'm wrong, but isn't the UK system intervention first choice and then surgery? I mean, the interventionist gets the first dibs in acute aneurysms, and then if they cannot coil, they will refer it to you. Isn't that the system in the UK or most of the Europe?
In
Unlike,
UK, no, in
yes,
UK, that is the system
yeah,
that we do offer interventionals the first go. But
yeah.
if I do say that, or for example, if there's a clot, or if I do say that that's a wide neck aneurysm or
That's
something
what I
like that,
meant.
we would, yeah.
For
We,
general aneurysms, yeah.
no,
For
no,
general,
we can always
80%.
override. The surgeon can
I
always
think
override.
what Parithos is saying, the first right of denial, I mean,
First right of
first right
denial is to
is
interventionalist, yeah.
I mean, that's true, correct. Not all over Europe. No, not all over Europe.
No,
It's
and
UK, it's very much there, not
UK is
all
very
over.
much there.
yeah,
I also
not
want to ask
Can
you
I,
one more question, sir. Has the MDT been audited? Has the utility of MDT been audited? Because you guys are so high on auditing. Has the MDT been audited?
yes. The
Has
the
the utility of MDT for normal garden variety ruptured aneurysm been audited?
Yes and no. The MDT has proven its value, cost effectiveness, and advantages in clinical medicine, but in cancer services, not in neurovascular services.
I'm asking
What
about
we,
neurovascular
that's
services.
right. No, we don't have an audit or a paper or a research of utility of the MDT. That's what I said, that I'm not sure, we don't have an evidence that the MDT will necessarily improve the patient outcome. It is the subspecialization and the volume of cases that we believe leads to a better outcome than the MDT itself. To answer your question, the answer is no. But in cancer specialties, yes,
Okay.
MDT does help.
And
can I make a point, Shashika?
Yes, sir.
Yeah, just to both Dr. Mishra and Dr. Parith. I'm a bit concerned about the hybrid neurosurgery program. Paritosh, when is the last time that you clipped an aneurysm?
1 week back.
And what
Yeah.
would be a ratio of clipping versus coiling?
I still do half half, but yeah, I think most people will do one third and two thirds. One third surgery.
I
One
don't know.
second.
I mean, that's
One
a
second.
huge number, but for you, because I personally feel you require a lifetime to get expertise in one of them. So to get an expertise in both is probably difficult. And Dr. Mishra's point that it's good to be a hybrid neurosurgeon just to attract, just to ensure that patients come to you. I might not kind of agree to that, but probably as a team, you should have a team which does both. But
Girish, I
I
mean,
have a concern that to be an expert in both, like that way endovascular thing is evolving, you need to be totally focused on that to get a particular level of expertise in that. And similarly with surgery, now complex, now what is left is complex aneurysms, and to learn bypass surgeries, it's not easy. It takes a lifetime, I guess, to master that. To be master of both, I guess, is I would find it challenging.
Girish, I was a very strong proponent of what you were saying just now. But I think this is a question of survival. If the neurosurgeons do not get trained in endovascular, then they will not get the patients. I mean, I'm telling you this
No,
in
no, no. I'm
especially.
not saying that. I'm not saying that it should be the interventional radiologist doing. I guess an neurosurgeon trains in endovascular does endovascular, and a neurosurgeon who trains in vascular does vascular. It should be a team. So if
Can I?
a patient
Can I?
comes to me, I have a team. I have a surgeon. If you decide that it is going to be endovascular, it is the neurosurgeon who does that endovascular. But the same neurosurgeon, I guess, there's a lack of equipoise when you tend to be biased towards endovascular, probably because it is shorter duration, and it's a general inclination to be that.
Can I say one thing with all my biases? Nobody asks any question to a skull-based surgeon who is also doing DBS, who is also doing spine, who is also doing endoscopic skull-based these questions. Nobody asks a skull-based surgeon who is doing open skull-based and endoscopic skull-based this question. Nobody does. People only ask this question to a cerebrovascular surgeon who is doing open and endovascular surgery. It is a skill. You can learn it. If you can learn to operate both spine and petroclavial meningiomas, of course you can learn this skill in a matter of 1 year. You have the thing. So it's not that difficult. I keep telling the younger neurosurgeons to get trained in the endovascular, spend 1 year. I have told Shiv Shankar so many times, get trained. It's not that difficult. And again, nobody asks Manas that he does DBS, endoscopic skull base, and MIS spine on the same day. They don't get questioned. The only people who get questioned is hybrid neurosurgeons. How can you clip and coil in the same time? It's not fair. It's not fair on us. We spend 66% of our practice for vascular neurosurgery. So we treat the same specialty of disease with different things. And you see vascular surgeons, they do endovascular and open surgery all the time. All the time. So they are the model that we have to do practice, not the cardiologists who have CTVS surgeons who have left cardiology and are left only with 5% of the disease. So that's the model. Sorry.
Yeah, thank you, sir. The one question for me from my side to all the moderators, speakers, and even the panelists. So the thing is that, as Dr. Paritosh Pandey sir told, there are very few centers where neurosurgeons does both clipping and endovascular things. So in most of the training institutes, the radiologists are not giving up the department of intervention for neurosurgeons. And most of the neurosurgeons who are getting trained, I'm talking about young colleagues who are getting trained and coming out. So they are not exposed to the endovascular thing completely. So either if they want to have that at least hang of endovascular surgery, they have to do either a fellowship or something in that way, and that won't be sufficient. So what should be the guidelines for the training of these neurosurgeons when we expect a neurosurgeon to do both coiling and clipping? So how the institute should follow and all the teaching institutes should follow training of a neurovascular surgeon on a dual train basis.
Sorry, can I say, Shiv Shankar, is it not 3 years that the MCH training requires? 3 years? Is that
Yes,
correct?
3 years.
Okay.
3 years.
Yeah, in 3 years it's too a short period to get expertise in complex cranial or complex cases anyway. If you add interventional training into that, then it will further dilute your surgical experience. And actually, I agree with Dr. Mishra and Dr. Menon that if I was starting neurosurgery now, and if I had passed my MCH now, my aim would be to become as skilled, as experienced as Dr. Bachchan Mishra. That would be my endpoint in my career. Now, if I was to do 3 years of training, out of which 1 year is in endovascular or a fellowship after that, I don't think I will have enough cases, enough experience, and enough justice to do either of them. That's
No,
my
I'm not
worry.
asking about the hands-on training,
I
sir.
think Kishore Shiv Shankar. I mean, what Shiv Shankar you are saying is the ideal way to do it, right? I don't think. I mean, you don't need to have. I mean, I agree with Kishore that is short. Time is short, but now is many centers are 6 years, and it's not 3 years anymore because it's post MBBS. You know that many centers are 6 years. It's not post MES. Majority probably neurosurgeons who are coming out today are post MBBS. You know so it's a 6 year course. But that's not the point. Point is, I think what you are saying, Shiv Shankar, is the ideal way to do it. It may not be that you have to be spend time 1 year in of the 3 years, even if you are a post MS, 3 years out, 1 year in endovascular. It's a question of getting exposed to endovascular training during your neurosurgery, MCH or DNB training, right? So that is,
Yes.
I think that's ideal. The problem is it's a turf battle. It's a turf battle, at least in India, except probably the only government institute which has that opportunity is GB Pant. I don't think any other government institute, if tell me if I'm wrong, Paritos or Girish, I don't think any other government institute has that option of the resident neurosurgery getting exposed to my endovascular therapy. That's the problem. That is the major problem.
Can I say we are doing it at KM. So
Okay, yeah,
now
yes.
our residents are getting trained. I was telling Paritosh also. So we should incorporate training wherever there is high volume neurosurgeons, hybrid neurosurgeon like me and other departments are doing intervention as well as clipping. And this would be the ideal way, at least for exposure. But answering your question, Dr. Shiv Shankar, the issue is after 3 years, we need to have a training separately for intervention. That is the protocol even today followed in our country. Right from the DNB or FNB program as well as the MCS program, most of us are trained after we finish MCH either 3 years or 6 years. So it's an additional training which is now currently being practiced, and that's how we are exposed to both uh, conventional clipping as well as interventions. And we are fortunate to do that because our residents now I'm training apart from the fellowship program in our department. So most of these residents are getting exposed to dual train. They are fortunate, as in is happening in GB Pant also.
Yeah.
Yes,
So
sir. No.
can I say something, Shiv Shankar, here? Because I've been listening to all the talks.
Yes, yes, sir.
I being more of stroke, more of epilepsy and neuro-oncology, I
Today,
think
yes.
MDT works. And I have been involved both in neuro-oncology and epilepsy against the tides. And 25 years we have successfully, in spite of all the, apart from what Kishore is saying from UK, MDT certainly can work in India. And we have proved that in epilepsy, only epilepsy care which works as MDT plus neuro-oncology. So I think I've been telling Dr. Dange that we should have an MDT right from the day he has taken this thing. And he's very right. Now we have this 3 + 2 years. So it's not only 3 years neurosurgery, where as he correctly mentioned that all residents get training in endovascular, plus 2 years of post MCH training, where they are exposed to both when they are off the typical ward duties, but they do get advanced training in endovascular and clipping. So what he says is correct. Now they are doing much beyond what as Dr. Professor Mishra sir said that at GBPAN KM certainly offers both cases. Yes, exposure mainly. Not they may not be primary surgeons in clipping, but certainly they see a lot of both of this. My concern is different. My concern is that most of the cases which are referred for vascular treatment now are not neurosurgeons, radiologists, or neurologists. This thing. There are direct general practitioners who are referring it for coiling to radiologists. So not even neurologists or neurosurgeons are involved in this. And we see these patients when they have a bleed or they have rebleed, hydrocephalus, EVDs and all that. So that is a major concern. in major institute also, cost is a concern. There are patients waiting in our ward for funds. There are cases for FDs or, stent acid coiling, but Ayushman offers a limited period. So they are waiting here. The waiting period is more. In that case, they are exposed to all the complications of what an aneurysm surgery can have. And I think all the aneurysms cannot be grouped together. So maybe paraclonid aneurysms are very difficult, dorsally directed aneurysm are difficult. So they require a different kind of level of expertise plus bypasses. So I think a straightforward ACOM, MCA, or DACA aneurysm can be attempted reasonably well by many neurosurgeons who are trained adequately. But yes, certain cases do require expertise. So I think the answer whether hybrid should do or this thing is all depends upon the situation. I think we should discuss only paraclonide. I mean, how many people are successfully clipping paraclonide and what is the results of endovascular? And I'm given to understand that dorsally directed aneurysms, whether it is surgery or endovascular, are difficult to treat. So what about those? I think we should not categorize aneurysms where rather than talking aneurysm pathology as a whole. Now there is a time have come of subset of aneurysms where they are difficult to coil, difficult to clip, and go by that with expertise and training. So that's
Jimdar is you're in between. You went off. I mean, we couldn't hear you for a couple of minutes. No, we could. You could hear only for a couple of minutes. You were
yeah.
off
So
the net.
I feel that the subset of aneurysms should be now dealt individually rather than grouping aneurysms as a whole. So I'm sure that we are clipping.
No. See the MDT. See the epilepsy and cancer. I mean, you just don't have a choice. It is so. I mean, the especially the cancer. I mean, the oncology is so fastly moving. There is so much is happening. I mean, 5 years back, what was it? 1 year back, what was it? Things are changing.
We are finding
You
it
have
difficult
to have.
now.
Yes, you have to have the pathologist, oncopathologist, neuropathologist. I mean, oncologist, neuro-oncologist, medical oncologist, everybody to know what's happening. I mean, and this is and this good thing. It's a very, very good thing because people are getting treated now, which was not happening before. I mean, probably every year things are changing, and that's a good thing. Vascular is not so much of a change is not so dramatic, other than that new devices are coming, which as I say, I am a skeptic. The new devices, why are they coming? The new devices. If 10 years back it was the gold standard, whatever they're doing, why suddenly it changed after 5 years? Why is suddenly changing now? I mean, very nice. I mean, it's beautiful devices, very attractive slides. I mean, Nitin presented beautifully in the cases. But 2 years, 10 years, 5 years has nothing to do with an aneurysm. Aneurysm is for life. But what I think Paritosh talked about, the short term, what is the patient is interested. But paradoxically, if the patient family is very well educated, they understand than the patient family which is not educated. The patient family who is not educated, he is not prepared to open this skull. No. खोपड़ी खोलेगा तो मैं मर जाएगा खत्म. So that is the problem.
Yeah, two things. I'm not against MDT. I'm not saying that MDT doesn't work. I said blanket MDT for all cases is unlikely to work. And that dilutes the purpose where you actually want to discuss a complicated case. So if you discuss both a giant paraclinoid aneurysm as well as a 5 mm ACOM aneurysms in the same MDT, then you're just doing nothing. What I'm trying to say is that you should, or we should, have unruptured aneurysms, recurrent aneurysms, very complicated aneurysms in these MDT, and most of the other things are general things.
No, Paritosh, I think this is a rule. Now, Europe, you cannot operate aneurysm. Like in UK, though, of course, it is the first right of denial is endovascular. But in whole of Europe, they have to have a joint consultation. I mean, that is the standard of care.
I also want to give a very inadequate answer to Dr. Mishra why all these devices are there. One, of course, is commercial reasons. There are many companies, so they want to do newer devices and newer patents and things like that. The other thing is the ease of treatment. So what used to be more difficult treatment with, say, stent coil has been replaced by an easier treatment like FD. Same thing as what used to be for a wide neck bifurcation aneurysm, two stents, one coil, these kind of has been replaced by intrasaccular flow.
No,
digestion device.
I'm not saying, Paritosh,
Yeah. So
I think I did not make my point clear. My Sorry, I am muted. Okay. No, my point is not that. I'm not saying it is not developing. I'm not saying that it is not good to have it. I'm not even saying that it is industry driven. I'm not saying that. What I'm saying is 5 years back, these were the gold standard, right? 10 years back, these were the ultimate. If it was an ultimate 10 years back, how is it changed
It's
now?
not an
That's
ultimate.
my
It is not
question.
an ultimate, sir. It is. There are. It's easier
No,
way of
I mean,
thinking. So I'm
people
saying,
kept this is the flow diameter will change. That is how it is happening. Whereas the clipping has not changed. I mean, the
no, I agree
bypass
with
was
you.
there maybe 40 years back, right?
No, I
See,
agree with you.
the only thing is the expertise actually.
Yeah. Most of the
So
advances
the
are
moment a
driven
new
by ease
generation
of use.
thing,
Sorry.
the moment a new generation thing comes, the last generation becomes, kind of is not so good. There is a statement. I don't know whether there is a Belial law. There is a statement in surgical principles of surgery. There is I think one of these quotes is, as long as your surgery is not the same surgery is right after 10 years, this is not the best surgery. You understand what I'm saying? So this is the movement is so fast. That's the problem.
Yeah.
Yes, sir. Thank you, sir. I think it's almost 10:20 now. So I think most of the questions were
So you have
answered
the
by.
last word.
Yes, sir. So can we conclude, sir? I think if the questions are answered, it is
Yes, please go ahead.
Yeah,
Yeah, please.
I have learned a lot in this from
true, sir.
Professor Mishra, now Kishore and Paritoj and Nitin and all. I have learned a lot.
Yes, sir.
Very
Thank
much.
you. Thank you very much for this wonderful academic phase. It was a great learning. And I take the pride of sharing this with everyone because almost 50 were the delegates who attended. And almost this webinar will be seen by 200 to 300 later on once we say the YouTube link. And really heartfelt gratitude to my eminent faculty, Girish Mansar, my teacher, Dr. Nitin Dange, and Dr. Kishore Chaudhary. And as we all agree that medical technology is evolving to decrease the mortality and morbidity with the minimal invasiveness, but we must embrace our updates and evolve ourselves, at least for my age and the younger colleagues, that as it is concluded, dual trained would be better so that we can follow both the things and we can do a greater justice to the patients. But the very purpose of this webinar was to help the younger colleagues understand the techniques, the technology, pros and cons, and to make them well informed for the patient's betterment and to take a good decisions. And remember that there are still many neurovascular diseases where the standard of care is still neurovascular surgery, and still there are no good answers for from the end of endovascular surgery. So we need to possess this art, and we need to learn, and we need to learn and follow the masters. And we all conclude by saying that there is no one size that fits all. So choice should be tailored, and consent should be team based. And it was really great learning, and I really thank all speakers, panelists, and moderators, and all our viewers. Thank you, and good night, sir.
Thank you very
Thank you.
much.
Bye-bye.
Thank you very much. Good night.
Thank you.
Thank you, sir.
Thank you. Thank you. Good night.
Thank you, sir. Good night. Good night.